Good evening, colleagues from Adelaide, Australia, where at the time you're watching this, it's 3:30 in the morning. So I hope you'll forgive me if I'm not out of bed to do a live discussion with you. However, I hope my talk will be useful in understanding the background to many modern developments that are occurring around the world in PCOS. And I do hope that these will extend to you in the Middle East. I will just share my screen with you now. So I'm speaking on behalf of the International PCOS Network, which is a group of people across the world, ranging from China to the United States, from Finland through to New Zealand, in which we've looked through the evidence base behind many of the things that we want to do in PCOS. And we've come up with guidelines that I hope would be valuable for you. I also work at the Robinson Research Institute, which is a major research group in the University of Adelaide. What is PCOS? Well, we've all heard about the Stein-Leventhal syndrome, which was discovered by those two gynecologists in the 1930s. And they found large pearly white ovaries with large cysts around the periphery when the ovary was dissected. Since then, however, there have been many different variations described, and a dermatologist, endocrinologist, gynecologist, and psychologist all have different perspectives on patients with PCOS. In addition, we've got a problem with the name PCOS because the cysts are not really cysts, they contain follicles. And also, many patients with polycystic ovary syndrome don't indeed have abnormal ovaries. It's also been recognized that it's not just a gynecological, but it's also a metabolic problem. So we're dealing with a prevalent, complex condition with health and economic burdens that are considerable and linked very much to obesity as it rises throughout the world. In Australia, we've understood that many patients are unhappy with the length of time it takes to make a diagnosis. They have very poor experience of diagnosis, with one doctor saying they have it and others not. The emotional side has been underappreciated, and often patients are not investigated for metabolic risks. There's very poor patient information available, especially since most of this comes from fertility clinic websites. There's little information about lifestyle management, and the prevalence is extremely high, probably 8 to 13% of all patients in the reproductive age. So what we've tried to do is to set out a way for health professionals to make more consistent management, to give good education to patients and doctors, and to provide evidence-based guidelines. And that's what I'd like to cover with you in a few minutes today. So what are the causes of PCOS? Well, it's clear there's some genetic indications through the genome-wide associations, but this only explains a small percentage and is certainly not diagnostic. Increasingly, AMH appears to be playing a role, and I'll discuss that in a minute. Insulin resistance has been recognized for the past 4 decades and may aggravate the condition. Increased androgens, particularly as shown in animal studies, seem to cause PCOS. And there's good evidence now that intrauterine events somehow program the ovary. So if we look at how these fit in, the genetics and tendency to PCOS or even intrauterine exposure contribute, but there also is a lifestyle component. And as a result, we end up with raised androgens and increased insulin. We often have changes occurring in the ovary, and there's an increased risk of diabetes and metabolic syndrome, hirsutism and acne, and reproductive issues, including infertility. All of this contributes to psychosocial issues, including body image, self-esteem, depression, and anxiety. There's some new concepts in the etiology of PCOS, largely coming out of a French group. We know that AMH has increased in PCOS. Excuse me. And this AMH seems to work on receptors on the GnRH neurons. This affects GnRH release and leads to characteristic changes in pulsatility, and this contributes to the anovulation. If this hypothesis is true, we're going to develop some brand new treatments for PCOS. So an overview of PCOS is that we have reproductive phenotypes, psychological ones, and metabolic, and often these overlap. But different doctors are seeing different aspects, and therefore PCOS is often misdiagnosed. So in the PCOS guideline, this is an international collaboration. We have 5 guideline development groups across 7 continents with 37 leading societies and over 700 PCOS experts. It's taken us over 3 years to complete, and it's been approved by our National Health and Medical Research Council in Australia. It's important to recognize what evidence is. Many of us are very scared of just relying on randomized controlled trials and Cochrane, but evidence from research is extremely important. Where that evidence is missing, we have to rely on good clinical expertise and experience. And so we don't discount that in evidence-based practice. Patient and consumer perspective is incredibly important. And so that's got to be taken into consideration. And obviously cost effectiveness. If we have a treatment that's very, very expensive, that may be less based on good evidence than cheaper, less effective treatments. The diagnostic criteria for PCOS have been problematic for many years, and there are currently 3. There's the NIH criteria, Rotterdam, and not shown on this diagram, the AE-PCOS one. The original NIH incorporated menstrual irregularity with anovulation and clinical or biochemical hyperandrogenism with exclusion of many other causes. The Rotterdam criteria adds polycystic ovaries on ultrasound, and you have to have 2 out of 3 of those. The NIH has now accepted that the Rotterdam criteria is the better one, and so we have used this exclusively through all our discussions, and I would advise you also to use that in your practice. So how do we make the diagnosis using these criteria? Well, it's suggested that there are various steps. The first is that if there are irregular cycles and clinical hyperandrogenism, hirsutism, you don't need to do an ultrasound, you've got the diagnosis. If, however, clinical hyperandrogenism is missing, then you can test for biochemical. So this is a blood test for testosterone and SHBG. If at the end of that you still have only one criteria, then you can go on and do ultrasound. However, it's advocated that for adolescents, ultrasound is not indicated because multifollicular ovaries persist throughout adolescence and only disappear about 8 years post-menarche. We need to consider other conditions such as thyroid, prolactin, early menopause, and Cushing syndrome. But these can all be based on clinical criteria if you think they're missing. A word about menstrual cycles. When we look at adolescent girls, in the first year post-menarche, most of them are anovulatory. However, over the next couple of years, most of the cycles become ovulatory. And therefore, we're advocating you wait for 8 years before you claim that someone is anovulatory. However, many abnormal cycles in adolescence persist through to adulthood. And so you may have an index of suspicion during adolescence, which then gets translated through to firm diagnosis in the early 20s. How do we assess hirsutism and clinical hyperandrogenism? Well, there's a very well-known Ferriman-Galway score, which is shown on the right of the slide. And this is quite simple, and you can score this within minutes when you examine your patient. Generally, levels over 4 to 6 indicate hirsutism, but we need to bear in mind the ethnic background of the patient. Acne may be valuable, particularly in people of East Asian background, but acne is very common in many normal people. What about biochemical hyperandrogenism? Well, we're advocating that you measure testosterone and sex hormone binding globulin to work out free androgen index, or there are various formulae that can be used using albumin that would work out the free or bioavailable testosterone. The very best assays are liquid chromatography mass spectrometry.
Professor Hassan,
thank you very much.
From Dr. Hassan.
Thank you very much. At this point, in this excellent presentation,
yes,
we have to stress 8 facts that have been mentioned by Professor Robert Norman. Time to diagnosis has to be satisfactory for patients, and this is an important concept, and that the phenomenon of PCOS include reproductive, metabolic, and psychological issues that have to be taken into consideration, and this is our role as a foundation to take care of this, and that consistent management among physicians is very important, and this is our role as a foundation also to establish this. And Professor Norman would recommended that we use the Rotterdam criteria. So in the foundation in EFRI, we will use the Rotterdam criteria rather than the other 2 criteria for diagnosis. He put a very nice algorithm, and I took his permission to put the video on our YouTube, on EFRI YouTube, to put it in our groups. And if you want to distribute the algorithm, I have his permission to do this. And also he stressed the fact that between menarche and a diagnosis of PCOS in adolescents, 8 years have to pass. Thank you very much. Continue, please.
But these are not available all over the world and can be quite expensive. The use of androstenedione or DHES can be used if you've got no other assay, but they're not very reliable. A word of caution, some assays are available that say they measure free androgen directly, and these have been shown to be very unreliable. What about ultrasound? As I've mentioned before, ultrasound shouldn't be used for women who are less than 8 years from their menarche, because multifollicular ovaries are extremely common at this stage. However, for adult women, using modern transducers, that's with a transducer of more than 8 megahertz vaginally, we would say that you have to have at least 20 follicles that are present, or an ovarian volume of over 10 mils. Now, for women who are not sexually active and who don't want transvaginal ultrasound, abdominal ultrasound is still acceptable, and you should use the same criteria. If the woman is very large and the ovary is difficult to see in detail, ovarian volume can be quite a useful diagnostic parameter. So these are the criteria we talk about in the guideline, that we should avoid use in adolescents. The threshold will be changed as ultrasound gets better and better, and so 20 follicles may be the minimum at the moment. And we want to see at least 20 follicles under the current criteria. As you will all know, AMH is extremely high in women with polycystic ovary morphology, and it's quite useful as an alternative to ultrasound. But you cannot make a diagnosis of the syndrome on the basis of just AMH alone. AMH may substitute for the ultrasound, but at the moment we're not advocating that until we get better, more reliable AMH assays that can be used around the world. What about metabolic risk assessment? Well, every patient should have weight and BMI done, and this should be monitored at each visit or at least every year as part of our clinical practice. Glucose screening is mandatory. So we can either use a hemoglobin A1 or fasting glucose, or we can do a glucose tolerance test, particularly if there are other diabetic risk factors. And if the woman is planning a pregnancy, it's extremely important to do it pre-conception and also in pregnancy. It's important to check blood pressure every year and lipid screening, particularly for those who are at risk. As an aside, I would like to suggest to you that in very large women, you should consider the diagnosis of obstructive sleep apnea. And this needs to be treated by a respiratory physician if it's found to be present. I know all of you will know about endometrial cancer and how you need to watch for that. Our guideline covers a lot to do with pharmacology. So it covers the use of a contraceptive pill, the use of anti-androgen agents, metformin for metabolic abnormalities, and other drugs for lipid abnormalities. I'm not going to cover that in this lecture, but it's well covered in our guideline. Emotional well-being is extremely important, with anxiety, depression, and poor self-esteem found in many, many patients. I believe we as gynecologists need to be handling or referring this, but it's not something that I'm going to cover in this lecture. The very first treatment for all patients, regardless of fertility or not, is lifestyle intervention. And that includes good diet, good exercise, and particularly prevention of weight gain in adolescent women. There's no particular diet that's better than the other, but we certainly need to encourage significant weight loss in patients with PCOS who are overweight. We have good information for patients who want to work on their lifestyle, and you can find these again in our guideline documents. Let's finally end up with infertility, as I know this will be the main thing that you're concerned about. We have a lot of evidence on anovulation treatment in PCOS, and overwhelmingly letrozole is the first-line pharmacological treatment after lifestyle management. Clomiphene citrate is still a very useful drug, but not as effective as letrozole. However, if you combine clomiphene citrate with metformin, particularly for overweight women, it seems to be quite effective. All of you will know that metformin can be used on its own in anovulatory women with PCOS, particularly if they're not in particular hurry to become pregnant. The diagrams below show the trials that have been done versus letrozole versus clomiphene, etc. And most of these have been between metformin and clomiphene and letrozole and clomiphene. If orals fail, many of you will be confident to use FSH. So the gonadotrophins are second-line therapy after lifestyle and after oral drugs. It's important to note that gonadotrophins are expensive, need high expertise, need very good monitoring, and have a significant risk of multiple pregnancy. We therefore advocate low-dose gonadotrophin protocols with monofollicular development. And despite the marketing, there probably is almost no difference in the clinical efficacy of all the different gonadotrophins. We'd like to emphasize, although this is very much a cultural and geographical view, that if there are more than 3 follicles, that you should not proceed because the risks of multiple pregnancy are significant. What about laparoscopic ovarian drilling? This is also a second-line therapy for women with PCOS, but it could become first-line if you do not have access to good FSH or IVF facilities. The risks should be explained very clearly to all patients, the cost, and also the fact that adhesions may occur following laparoscopic drilling. There is very good evidence that AMH levels drop, and therefore you are reducing the follicle pool as a result. What about IVF? I feel very strongly, and I think the guideline development group also do, that IVF is useful for patients in which all else has failed, or for which there's another indication, including male factor, endometriosis, etc. So IVF is acceptable. We believe that elective embryo transfer should be used, but accept that healthcare services are quite different around the world. Women with PCOS should understand that IVF has a cost, that there's increased risk of ovarian hyperstimulation, and that there are risks in IVF that don't exist in some of the other forms of treatment. There, again, is no evidence that any particular FSH is better than the other, but there are strong evidence that gonadotrophin-releasing hormone antagonist cycles, short cycles, are better than the long protocol for reducing OHSS, and the use of a GnRH agonist to trigger final maturation of the oocyte is better than using HCG in terms of OHSS. There's also good evidence that freeze-all cycles may be quite valuable in these patients. I know in the rest of the evening you're going to discuss many of these issues. Let me end up by talking about our research translation program that's available to you. Our aim was to build the capacity of health professionals to deliver high quality service to patients with PCOS. We have PCOS clinics. We want to increase the health literacy of PCOS health consumers and to get early diagnosis and good outcomes. And we want good evidence-based models of care. You can find this document on the website under Monash PCOS, and you can find our publications in fertility and sterility, human reproduction, and clinical endocrinology. Exactly the same article in all 3 journals at the same time. We've presented our work at more than 60 conferences across the world and continue to do so. On our website, you'll find tools for general practitioners, lots of information for patients, sheets that you can print out for free and give to your patients, and algorithms to help you make decisions about infertility and many other issues. We have a wonderful PCOS app. This is the first evidence-based PCOS app, and it's available for Android and also for Apple. It's free. It has a great design with all evidence-based information for patients at their level of understanding. It's currently available in English, Mandarin, Vietnamese, Hindi, and Spanish, and we would be very interested to help you in the Middle East develop it for your patients. The app also helps patients.
Okay. Any comment from Professor Hassan for these very nice applications?
Yes, please, Dr. Ashraf, if you would kindly contact Professor Robert Norman to ask for what he declared to help us install PCOS app for foundation members, because this is a very good tool. It has all the guidelines, and he is willing to help us do this. Okay.
Yes, I think we will announce everything about that on the PCOS group. We will soon, in few minutes, we will share the link, and we will welcome all of the attendees to be our guests and share our activity and invite their friends and colleagues.
Thank you very much, my dear.
Okay.
Please
continue the video.
The doctor that they prepared beforehand. If you want to develop more of your skills in PCOS, we've got an accredited education module. There's a small cost for this, but it's based on the UK-based Future Learn program, and it's accredited with PEAT education bodies. It lasts 3 weeks, and it's been available since 2019. We have a great series of e-booklets on a number of aspects of PCOS. We've designed these with consumers, and they're good for people ranging from low to high health literacy. Again, these can be downloaded from our website for free and given to your patients as you see fit. And finally, we can...
again, Ashraf, would you please contact Professor Norman? EFRI is willing to pay this small fee for its members to get the accredited module for PCOS learning, and also for the e-booklets. The e-booklets are free, but for the accredited program, for those who want, we can add this to our education program, and EFRI can pay for this. Okay?
Definitely, and the next step about translation program, I think we have a very important task to help our Arabian patients to translate those leaflets and translate this knowledge. We will give full information about our interested colleagues in that on the groups within the next week, I hope, and we will excuse Professor Noor. And another very important issue, if any of the attendees has a direct question that he likes to ask Professor Norman, we will contact him, and we will inform you about all questions and answers about this very important guideline presentation in our group. Okay, Samah, can you continue?
Continuing with our PCOS translation program, we have extensive evaluation. We have a data hub where we're collecting information, and we're welcoming partnerships to extend the program. So if any of you want to be involved, if you want to extend what we've done to your region and to your patients, please don't hesitate to approach me. So thank you everyone for listening. I hope that the presentations come across reasonably well, and I would be very happy to answer any questions by email at robert.norman@adelaide.edu.au. Good luck for the rest of your meeting, and good night.